Okay, so everyone, this is Karen Wong, and she's one of our CCU pharmacists, and she's going to be talking to us about sedation in the cardiac critical care unit.
Okay. All right, so we will begin, and there's so much to talk about in terms of sedation. So I tried to isolate into maybe 3 aspects, but it really is kind of a general overview. Just as a disclosure, there's no conflict of interest, and so we'll proceed. And so these are the 3 aspects of sedation that I'm going to be speaking about today. One is our general approach to sedation in the cardiac critical care. Second is the pharmacokinetics and pharmacology of the agents that we typically use on our unit. And then the last part is how we wean these medications off. So let's go through just our general approaches. I have 3 cases here, just kind of in order of simplicity. And this is a simple case, a patient with ASD, no home meds, having adequate weight gain, and here for ASD closure. And the operation was straightforward and no residual lesions, extubated in the OR and admitted to our critical care unit. So what is our approach, our general approach to these straightforward cases? Our general approach is that we start off with a multimodal approach. Back maybe 20, 30 years ago when I first started here, we were very heavy on the opioids in terms of pain and sedation. And now the trend has changed that we use more of a multimodal approach in trying to limit our exposure to opioids for those cases that are more less straightforward. So in our approach here, we use Tylenol at 15 per kilo per dose every 4 hours, up to 4 grams a day, for a maximum of 72 hours. And if their bleeding is under control and they don't really have a lot of renal dysfunction, we will add on non-steroidal, such as ketorolac, for 48 hours. And then if needed, there's morphine boluses that the nurses can use. And they might have to consider a background infusion of morphine if we find that they're requiring several, like at least 2 or 3 boluses of morphine. So here's a sample of a moderate case where a patient is here for tetralogy of flow repair, and they might have been in the OR with 2 pump runs and no residual lesions. But in this case, they were admitted intubated because there was concerns for jet. So how would we handle kind of these cases where they do come back intubated? Just like this simple case, we do start off with Tylenol and 15 per kilo per dose every 4, up to 4 grams per day for 72 hours. As well, we can use ketorolac as well. And then we will start off with a morphine infusion of 20 mics per kilo per hour, and then using the morphine boluses as needed. And the infusion might be titrated up to 30 or even 40 sometimes if they're still in discomfort or in pain. And in these cases, we will add on dexmedetomidine infusion, usually starting at around 0.5 mics per kilo per hour, and then titrate it as necessary. What about a sample complex case? Say, for example, a child comes in with coarct and VSD, and they're here for coarct repair and VSD closure. But let's say in the OR, it's been complicated and that they require ECMO and maybe redo of coarct repair. So in these kind of cases, we'll have these patients on dexmedetomidine for the sedation as well as pain control at a higher dose, 1.5 mics per kilo per hour, or titrating up to that point. And morphine infusion as well to titrate up to 50 mics per kilo per hour. And if we find that at those upper, higher doses of the morphine infusion that it's not helping them with their pain control, then we would consider switching to a different opioid. And if sedation is really an issue too, we will consider adding on a benzodiazepine. So as you can see, depending on the complexity of the case, we'll use the Tylenol and non-steroidal ketorolac. And if there's more pain control that's needed, starting off with an opioid infusion. And if more pain control is needed and sedation is really an issue, we'll add on dexmedetomidine and benzo as that last agent. Which I find over the years, the trends change because, as I said, initially it was much more opioid heavy. And then there was a period of time where we were benzodiazepine heavy for sedation. And now with the availability of dexmedetomidine, we do see a more usage of dexmedetomidine and much less use of the benzos. So trends change. Now, this was a study done in 2016, and it was a survey of the sedation and analgesic practices amongst all the Canadian pediatric critical care units. And I have found just in the literature, there's at least 100 trials that compare all sorts of sedative trials. And just in general, we do find that there is no one sedative drug that is superior than another. There are the differences in the prescribing pattern amongst the countries, and the choice is usually determined by tradition and the familiarity rather than evidence-based practice. And minimizing the depth and the duration of the sedation seems to be the only marker that affects the duration of mechanical ventilation and the length of their ICU stay. So this survey was emailed out to 134 intensivists across 17 PICUs across Canada in 2016. And this survey found a response rate, they received a response rate of about 70%. And in that response, we found that withdrawal scores were used in about 65% of the centers across Canada. Delirium scores only used by 16%. And the practice of daily interruption of continuous sedation and analgesia was only practiced by 5% of the respondents. So that was interesting just to see how other centers, what their approach was towards sedation and pain. Now, I just pulled out this particular graph just because I'm focusing on sedation, although the survey asked for many, many other questions. But in terms of sedative choice, it appears that most centers across Canada, most common ones was midazolam and morphine infusion. And then if they didn't have an IV, chlorohydrate seemed to be the agent of choice used across Canada. Now, I'm going to move on now to the second part, which kind of looks at the agents that we actually use and focus more on the pharmacokinetics and the pharmacology of these particular agents. So just some general pharmacokinetic principles first. Now, this is a blood concentration versus time curve. And as you can see, when a drug is taken, here where if you follow my cursor, when the drug is taken, and in this case, it might be oral or any other route that the drug isn't directly going into the vascular space. So it could be an IM or sub-Q or transdermal. There is an absorption rate that happens at which the drug shows up in the vascular stream. And then when it hits the Cmax, which is the highest concentration of the drug in the blood, then the period of elimination starts to happen. And during the elimination where the body is getting rid of it, if they were to continuously measure the blood levels of the drug, there's something called half-life, which is the time that it takes for that drug to lose half of its maximum concentration. And then the drug level continues to fall until it hits the semen, where it means it's the lowest concentration of the drug in the blood system. AUC stands for the area under the curve, which really represents the overall drug exposure over time. Now, why I bring up the half-life is because we often we use the term half-life, or you hear people ask, what's the half-life of the drug? And it kind of gives us an idea of this next slide that I'm going to show you here. So the idea of half-life is important because it gives us an idea of how long it might take for a drug to reach steady state. So in this graph here, it shows like the drug concentration in the plasma versus time. And as we infuse a drug, it will slowly climb up until you see the plateau of the drug levels. And when it plateaus, that's the steady state. And the general principle is that it takes about 5 half-lives of a drug to reach its full effect, or to reach that steady state. So in this case, let's pretend that this concentration time curve is that of morphine infusion. So let's say your patient is on that infusion without a bolus, without a loading dose, and you simply are starting your patient on an infusion, say 10 mics per kilo per hour. Now, if your patient has like normal renal function and normal hepatic function, well, we know that the general half-life of morphine, assuming that they're not a PREM or anything like that, is roughly about 2 to 3 hours. There is a slight change in the half-life depending on the age and size of the child, but let's just say, for the sake of this example, that the general half-life of morphine is 2 to 3 hours. So if you were to start an infusion of morphine and you know that it takes about 5 half-lives, it would mean that it would take up to about 10 hours for that morphine to reach a steady state in the body. And why that is important is because sometimes we often find ourselves titrating the effect of the drug every few hours. And sometimes that's required because clinically they're in pain or they need more sedation. And so we will adjust things based on what you're seeing clinically at the bedside. But if we keep in mind some of these pharmacokinetic principles, it also runs the risk of accumulation. And with accumulation, then we run into problems with toxicity or side effects, and then we have to start weaning back down. So knowing the half-lives and keeping in mind that 5 half-lives to get the full effect, that just gives us another way of looking at what happens to the drug inside the body. This is similar, except that it's intermittent drug administration. So say we're giving it a morphine every 2 or every 4 hours. Again, we don't get that smooth curve like we do when we see an infusion, but it's still the same. It's still using the half-life of the drug, and then realizing that 5 half-lives gives you a new steady state. Now, if you were to have a patient where you're combining the two, where you're giving a bolus and then starting an infusion, then you get to the steady state much faster. I actually am missing a slide where it shows the combination, but basically you would see the line get up to steady state much sooner, because with the loading dose, it brings you up to that steady state quicker. So now I'm going to go through the pharmacology of the different agents, the sedatives that we use here in the CCCU. And we'll start off with the benzodiazepines. The pharmacologic effects of benzos that we all see at the bedside is, with the lower doses, we see an anti-anxiety effect. And it's as we up the dose a little bit more, then we start to see the patient a bit more sedated, and increase the dose further, say 50 per kilo, then we get into that hypnotic state. And then there are certain benzos that seem to help in seizure control as well, in particular clonazepam, midazolam, and clobazam. So these benzos have an anti-seizure effect, whereas lorazepam, midazolam, diazepam, we tend to use that more for the anxiety sedative or maybe even the hypnotic effects of the benzos. Now here's a pictorial diagram of how benzodiazepines work. You can see here 3 lines, A, B, and C, and I'll start off with section A, and that's a picture of the phospholipid bilayer of the membrane, and that tooth-looking thing is like a receptor. And in A, the receptor is a chloride channel receptor. When there's nothing sitting on the receptor, that receptor opening is closed, so the chloride ion can't move from one side of the membrane to the other side or one side of the cell to the other. Now, in the section B, you see this green circle that's attached to the receptor, and that represents GABA, which is GABA aminobutyric acid, which is the major inhibitory neurotransmitter in the central nervous system. When GABA binds to this receptor, what it does is it opens up the channel so that the chloride ion can move from one side to the other side of the membrane. And that leads to hyperpolarization of the cell. And then in section C, you see a blue, I don't know what that shape is, but that blue part is the representation of benzodiazepine that also binds onto the same receptor that GABA binds onto. And when both of them are binding onto that receptor, it really opens up that receptor for more chloride ions to move from one side of the cell to the other. And that entry of chloride hyperpolarizes that cell, making it difficult to depolarize, and therefore it reduces neuronal excitability. So benzodiazepine, in the most short form, is that it's like a GABA, it works with GABA on the same receptor. Now, what are the differences then between all these different benzos that we use? We talk about onset of action, and you guys at the bedside will often see that, and then the peak effect. But the half-life of the parent and the active metabolite is not something that we can see clinically, but it's important to keep in mind and to learn this as well too. So when I say the half-life of the parent drug would be the actual drug that you've just given, midazolam, lorazepam, or diazepam. And then a lot of times drugs go through a metabolism, usually through the liver. And once it's metabolized, the next question we always ask ourselves, the metabolite, is it active or not active? Active meaning, does it have certain effect? Or inactive mean it has no effect. It just sits there inactively. So this table shows that diazepam, we all know that diazepam is a longer acting benzo than the other two. And the reason for that is because of the active metabolite of diazepam. It actually breaks down to oxazepam, which the trade name is Syrax. And back in the day, Syrax was used a lot as a sleeping medication, but it was actually the active metabolite of diazepam. And so you can see the diazepam half-life can be 3 up to 100 hours. And the half-life of diazepam itself is 20 to 50 hours. So this is interesting to keep in mind that there is different half-lives of the drug. Mind you, clinically what we see though is that even though there are these long half-lives, I know we sometimes use these agents like every 2 hours, every 4 hours. So sometimes what we see pharmacokinetics-wise in terms of the blood levels might not be the same as pharmacodynamic, which is at the receptor level. That GABA receptor that I spoke to you about, or what happens inside the cell that causes the sedation effects. So there is a little bit of a gap between the kinetics of what happens of the blood levels in the blood and the pharmacodynamics part. Because sometimes people ask me, why is the half-life so long, but yet we don't see it lasting very long. So that is one of the reasons why. All right. A little bit more about the differences between the three. So we see midazolam is typically thought of as the shortest acting one. Lorazepam is the intermediate. Diazepam is the long acting one. However, the interesting thing about diazepam is because it's the most lipid soluble, if you were to just give yourself one dose of diazepam, it actually wouldn't last that long. And that is because it's so lipid soluble, it would get into your bloodstream. It would get into your across the blood-brain barrier very quickly and give you that effect fast, but then it would redistribute out from the blood-brain barrier from the brain side to the vascular side very quickly as well too, and that would contribute to a short acting property. However, if you were to give yourself diazepam every 4 hours for days and days, then it becomes a long-acting agent. Because it's so lipid soluble, it gets stored in the fat tissues, and that also contributes to its long-acting properties. Now, in terms of what happens if your patient's renal function goes off, the midazolam and diazepam does accumulate in renal dysfunction, whereas lorazepam does not. And then drug interactions. Whenever we see benzos, I keep in mind that they may have drug interactions because they are usually metabolized by this liver enzyme system that we call cytochrome P450 system. And midazolam and diazepam are broken down by these enzymes in the liver. That's the cytochrome P450. And that same enzyme is involved in interacting with other drugs too. Sorry, that particular enzyme is involved in metabolizing other drugs too. So these two, midazolam, diazepam, can interact with other medications. Whereas lorazepam is metabolized by a different liver system called glucuronidation, and not cytochrome P450 or the oxidation pathway. So lorazepam doesn't seem to have as many drug interactions. Now, case reports of tachyphylaxis, I put that under midazolam, and what that means is that there's been cases of a sudden decrease in the response to the drug, but these are more case reports, and then patients, or we continue to give more midazolam and find that it's still a poor response, and we give more, and that's the tachyphylaxis part. Now, lorazepam, there are cases of propylene glycol toxicity because propylene glycol is a solvent that's used in the is used in the formulation of lorazepam. And it's a solvent used to deliver lorazepam. So in the PREMs or patients that have really bad liver, or we use a lot of lorazepam, we do have to keep in mind the propensity or the cases of propylene glycol toxicity. And then IV diazepams can sometimes be irritating to a peripheral IV site, so we keep that in mind as well too. Now, midazolam is the only benzo that is stable in the aqueous solution, and so it's suitable for intramuscular injection. Lorazepam we can give the SL sublingual tablets orally too, and then even with rectal, we dilute the injection and we can give it rectally. And then diazepam, the tablets can be crushed and mixed with food or a small amount of water. And then for rectal use, diazepam can be given undiluted as well too. So these are some of the differences between the different sedatives that we use. So the next group, I put in here opioids. Now, I know we typically think of opioids as analgesics, and they are very potent analgesics. But one of the side effects of opioids, especially in the initial use, is sedation. So we can sometimes we can use it for their sedative properties as well. But we keep in mind that tolerance can happen to the sedative properties. So it might not be the most effective sedative, especially if it's the only agent being used long term. Now, this is a busy slide, I know. Oops. Let me go back here. This is a busy slide, so I'll try to walk you through it. But what I wanted to highlight are the differences between the three opioids. Now, in terms of potency, we know that morphine is our gold standard, and then hydromorph is 5 times as potent as morphine, and fentanyl is 100 times as potent as morphine. So what are some of the other differences? Well, historically, as I said, morphine is usually considered the gold standard because people are familiar with it. It's globally available. It's been around for a long time. Its kinetic and pharmacodynamic properties are well studied. So everyone knows and very familiar with how to use morphine. Now, hydromorph was first synthesized in the 1920s, but it's usually considered a second line agent, morphine. And then fentanyl was first synthesized in the 1950s, and it is a potent lipophilic synthetic agent. Interestingly enough, fentanyl was a molecule that was derived by alterating the structure of meperidine, or the other name for meperidine is demerol. Since the founder of fentanyl wanted to produce a more potent opioid than demerol, he altered the structure of demerol, and one of the compounds that came out of the alteration was the compound that he termed fentanyl. So I thought that was quite interesting to know. I didn't know fentanyl was derived from demerol. Now, the onset, because morphine is more hydrophilic, meaning it is more water soluble, it might take longer to cross the blood-brain barrier, and so it has a slightly slower onset of action. Hydromorphone is more fat soluble than morphine, so its onset is correspondingly just a little bit faster, but both morphine and hydromorph are slower than the very lipid soluble fentanyl. So because fentanyl is so lipid soluble, it crosses the blood-brain barrier very fast, and so it has the quickest onset. So this water to lipid ratio, it plays a role in how quickly we see it have effect. And we also use this ratio to realize that it redistributes out of the central nervous system back into the vascular space. So that shows clinically in its duration. So we all know that fentanyl is like quick acting, but short acting. And now we know why, because it's a lipophilic agent. It crosses into the cells very quickly and it comes out very quickly as well. And morphine is very hydrophilic, meaning it's more on the water side, so it's a little slower and it lasts a little bit longer. What else do I want to say here? They're all metabolized by the liver, and the side effects wise, we typically see, let's see, morphine will probably cause more like the nausea and constipation. It tends to release histamine more, so you get the pruritus. Fentanyl, we have to, has less of that nausea and less of that less of the hemodynamic instability. So, but however, there is the risk of chest wall rigidity with fentanyl, but that's usually with like bigger doses and very quick administration of the big doses of fentanyl can put us at risk of the chest wall rigidity. Now, the metabolism of morphine. The main metabolic pathway of morphine is through glucuronidation in the liver. And the whole point of metabolizing a drug is to make the metabolites more water soluble. And the reason for making it more water soluble is so that it can be excreted by the kidneys. So this slide just kind of shows you that morphine gets broken down to two metabolites, morphine 3 glucuronide and morphine 6 glucuronide. And it's just important for us to keep in mind that there's these active metabolites. So it's not just morphine that's hanging around, but the active metabolites are hanging around too. So when the kidneys become not working as well, then there's the risk of accumulating both the parent drug as well as the active metabolites. Now, chlorohydrate is the next sedative that we're going to explore. And it was first introduced into medical use in 1869 as the first synthetic sedative and hypnotic. But unlike opioids, it does produce sedation, but it has no analgesic properties. And as early as 1894, chlorohydrate was being used in children. Now, despite the availability of the newer agents, chlorohydrate remains a choice, especially if there is no IV available. However, it's starting to fall out of favor too, because now we have the dexmedetomidine and clonidine too. But nevertheless, we will still explore chlorohydrate. As I mentioned before, is often selected because there is an availability of an oral dosage form and its relatively mild adverse effect profile. But because it has an unpredictable onset, a longer duration, and there's no real reversal agent compared to opioids where you can use naloxone, it makes chlorohydrate not the most ideal sedative. Now, with single dose or short-term use, chlorohydrate is typically well tolerated. However, sometimes we also see common side effects with it, including respiratory depression, nausea and vomiting, maybe some confusion, headache, disorientation that can happen in up to 30% of patients. And a paradoxical agitation has been reported in 2 to 6% of the older pediatric patients. Now, it requires the kidneys to get rid of chlorohydrate. So if there's renal dysfunction, it can accumulate and sometimes lead to arrhythmia. So it's something that we keep in mind. How does chlorohydrate work? It works by first being absorbed very quickly, readily in the gastrointestinal tract, and it can therefore be given orally and rectally, and it gets converted in the liver and in erythrocytes by this enzyme to produce an active metabolite, TCE, which stands for trichloroethanol. And yes, I know most of us know that chlorohydrate gets converted to basically alcohol, which is the trichloroethanol. And that is the active metabolite, that's how it works. It's through that ethanol compound. And all these metabolites that are formed gets excreted in the kidney. Now, dexmedetomidine. So dexmedetomidine has advantages over benzos because it produces analgesia as well too, and it causes less respiratory depression, and it gives a relatively, qualitatively different type of sedation. Rather than just like knocking them out cold, they become just more comfortably sedated. And compared to lorazepam or midazolam, dexmedetomidine seems to result in less delirium and a shorter duration of mechanical ventilation in the studies, comparing those benzos to dexmed. Dexmedetomidine, the trade name is Precedex, and it works on the alpha-2 receptors. And in the next slide, I'll show you where the alpha-2 receptors are found. So it's known as an alpha-2 receptor agonist. Now, dexmedetomidine will bind a little bit to the alpha-1 receptor, but it's primarily more so on the alpha-2. Now, sometimes people ask, what's the difference between dexmedetomidine and clonidine? They know that it's similar, but what exactly is the difference? The difference is the selectivity of how much of the drug binds to alpha-2 versus alpha-1. Dexmedetomidine is 8 times more selective to the alpha-2 than clonidine. So its sedative effects, it binds to the locus coeruleus in the pons, and it binds to the G protein receptors and causes sedation over time. And the analgesic effects of dexmedetomidine is it binds to the dorsal horn of the spinal cord and therefore inhibiting substance P. Here is a general picture of where these receptors that I was talking about. Here you have 2 nerve endings, and between the nerve endings is like the synaptic cleft. And on one nerve ending, you can see an alpha-2 receptor, and on the other nerve ending is an alpha-1 receptor. Now, clonidine and dexmed primarily bind to this alpha-2 receptor, and when it does so, it causes a feedback, a negative feedback inhibition, meaning that it prevents further release of this norepinephrine to be released. And so that's the general pharmacology of the alpha-2 agents. What do we see clinically? Well, on the cardiovascular side, we will sometimes see vasoconstriction. What happens is there's vasoconstriction. So clinically, you might see an increase in blood pressure, especially with the loading doses of dexmedetomidine, because we use a bigger dose for the loading dose. and so we see that hypertensive effect with the loading dose. Now, with the infusion, there is the opposite effects. We get a centrosympatholysis, and so it results in hypotension with the infusion. Respiratory wise, we tend to be able to maintain the ventilation and airway patency with dexmed. And thermal regulation, sometimes we see it can be used to decrease shivering. It decreases vasoconstriction. So these are some of the effects of the alpha-2 agents. And all these A2, B, AR, they're just the different types of alpha-2 receptors, more from a pharmacology perspective. So what about the pharmacokinetics of dexmedetomidine? It is relatively rapid distribution. Its distribution half-life is only 6 minutes, means that it gets around quite quickly. It's protein bound, 94% protein binding. That's quite a lot of protein binding. And it is relatively short acting. Its half-life is only 1.5 to 2.5 hours in children, compared to morphine, which we said was 2 to 3 hours. Dexmed is shorter in half-life. It gets metabolized by the liver to inactive metabolites, and it's excreted by the kidneys. Now, there was a student that sent out a questionnaire across Canada to the level 3 NICUs and PICUs, wanting to collect the information across these ICUs in Canada to see what are the current practices for use of dexmed in neonates. And what are the attitudes and practices between neonatal and pediatric intensive care providers? And we actually answered as well too, and we got the results back from that survey, which I thought was interesting to to learn about. So this was the survey done by a pharmacy a candidate, an IWK health center. And so she was looking at the dexmedetomidine use, a nationwide survey. And as you can see here, the most, I guess, most popular indication for Dexmed was for sedation. And, you know, there are some centers that use it for analgesia and some for both sedation and analgesia. Now, in terms of its place in therapy, you can see here, you know, what percentages use it as a monotherapy or add-on to opioid or add-on to opioid and benzo, or add-on to opioid, benzo, and an adjunct, or never or rarely used. And it seems like most people use Dexmed as an add-on to opioid. So I think her study kind of validated the other study that I showed earlier, showing that we might use similar drugs, but we might all use it slightly differently. This was interesting as well too. Dexmedetomidine, what was the typical duration that patients were on it for before requiring a wean? And on average, it was reported as more than 96 hours, but a range of 24 to 120 hours. And how were the different centers weaning it by? And you can see they were weaning by a range of 0.05 to 0.25 mics per kilo per hour every 6 to 48 hours, or on average 0.1 mic per kilo per hour every 12. I think our weaning guideline says 0.2 mics per kilo per hour every, I think it was every 6 hours. Now, but as you can see, there's a wide range of how people are weaning things. Now, clonidine, what was the dexmedetomidine dose at the clonidine initiation? You can see there, on average, it's about, you know, starting at 0.5 mics per kilo per hour, they would consider adding on clonidine. And what was that overlap with using the two? About 12 hours. What starting dose of clonidine? On average, 2 mics per kilo per dose every 6 hours. That seems to match ours. And how do we wean clonidine? 0.5 mics per kilo per dose, and then stretch the interval. So that was interesting to see how other centers were doing things. What are the advantages, disadvantages, and barriers to using Dexmed? The advantages is that it can spare the opioid and benzos. So we don't have to use as high doses of those other two classes. It might be helpful with weaning other sedations, less risk of delirium. And but some of the disadvantages is maybe lack of knowledge or experience and lack of guidelines as to how to use it, maybe in the different populations, where is its role exactly. So that is more some of the barriers that were identified about using dexmedetomidine. Now moving back to clonidine, clonidine's ratio of alpha 2 to alpha 1 is 200 to 1. Dexmedetomidine ratio of alpha 2 to alpha 1 is 1600 to 1. And that's why there's this dexmedetomidine is 8 times more selective to alpha 2 compared to alpha 1, compared to clonidine. Now, clonidine, though, we really use it because it has an oral availability, and it can be used as an opioid-sparing agent. So that's why we've used it to treat opioid withdrawal. Or we find that our analgesia is getting up too high on the dose, and maybe we need to add on another agent. Clonidine or Dexmed becomes a good agent. So these are some of the other populations, burn patients. We've used this agent too. But when have we used Dexmed, similar like clonidine, when it's difficult to sedate and other sedatives tried, or we want to spare the amount of opioid, or around extubation time and they're still on large amounts of opioids, maybe if we start the dexmedetomidine, we can cut the amount of opioids significantly so that we're able to extubate on much less amounts of opioids. Or if they're not tolerating benzodiazepines, or we don't really want to use benzos, especially more in the neonatal population, then the alpha-2 agents might be a good option to use. Now, the precautions of use, though, that we have caution in heart block or severe left ventricular dysfunction. Bradycardia and sinus arrest have happened, so we have to watch out for that. The hypotension and bradycardia may be more pronounced in patients with hypovolemia or chronic hypertension. So we have to watch out for that hypotensive or bradycardic effects with the dexmedetomidine. What is the dose of dexmed that we use? I put the loading dose here, but typically in the cardiac ICU side, we don't generally use a loading dose just because we're hemodynamically a little bit more fragile. And the infusion range is usually between 0.5 to 2.5 mics per kilo per hour. It's quite friendly with most of the fluids. And what is the youngest reported gestational age? This was more from the literature and talking to my NICU colleagues, and that is as young as 24 weeks. But the difficulty is we don't have a lot of long-term neurobehavioral studies because dexmed is one of our newer agents. We don't know the long-term effects on its neurodevelopment. So that still needs to be considered, especially if we use it long-term. Now, cost and availability, as you can see here, this is just simply the vial costs. It's about $14 a vial for dexmed versus the benzos is like $1 or $4, that type of thing. But, you know, that's simply the drug cost itself. Yeah, that's all I'm going to say about the cost and availability. And we have standard syringe concentrations of 200 mics of dexmed in 50 mils or 400 mics in 50 mils. Those are our standard syringe concentrations here. What are the side effects of dexmedetomidine? Well, the blood pressure response to dexmedetomidine is often biphasic. Initially, there is a peripheral vasoconstriction, and so we see a systemic hypertension that can be seen really with the loading doses, especially when higher doses are used. And although the literature in children is limited, the episodes of hypertension appear all to be transient. That usually resolves in 30 minutes, within 30 minutes. Now there's a decrease in systolic blood pressure that can happen in up to 30% from the baseline. Even with those on a loading dose. Even though we said it's usually hypertension, we can sometimes see hypotension as well too. The fall in the systolic blood pressure though is less severe if the loading dose is omitted or is administered slowly. So therefore we tend to administer the loading dose if we do a loading dose over at least 10 minutes. Now, this is rarely clinically significant and is comparable in magnitude to the fall in blood pressure seen with midazolam and fentanyl. Higher dose infusion of 2 to 3 mics per kilo per hour can cause more profound hypotension. So the learning points of dexmed is that it's a highly specific alpha-2 agonist with sedative, anxiolytic, and analgesic properties. It has minimal effect on the respiratory drive, which is a key advantage, and it has numerous potential clinical applications, especially beneficial to those patients that are susceptible to airway compromise or respiratory depression. Now, this is a big slide that shows a summary of all the things that I talked about. The first three are the benzos. They basically work as a GABA agonist, and then there's the metabolites and which ones have active metabolites and what's the half-life of them and what are the major side effects of them. Then we have the chlorohydrate, dexmed, and then the opioids at the bottom. So if anything, this is a good chart to summarize all the things that we talked about earlier. The effect of ECMO on agents. what I really just want to point out is that fentanyl and benzos, because they're more lipophilic agents, they may bind to the circuitry, so theoretically some drug loss. However, clinically, we tend to titrate those type of agents, so we don't typically we don't typically have a separate dosing guideline for patients on ECMO. We will just titrate to effect. But it's to keep in mind that certain agents that are more lipophilic will bind more. Now, the last part is the guidelines for withdrawal. Now, this is just to show in sick kids, we have a weaning guidelines stored in folders that we're happy to share. And it's also on our main drive that's open to the public as well too. Some definitions: tolerance is a decrease in the drug's effect over time, or is the need to increase the dose to achieve the same effect. Withdrawal are all the signs and symptoms that occur when the drug is stopped suddenly. And physical dependence is the need to continue that agent to prevent withdrawal. These are some of the common side effects of withdrawal symptoms, kind of categorized in the central nervous system, the GI, and the autonomic systems. Who are the ones that we have to wean? They are typically, in general, those that have been on things for more than 5 days. We will also take into account how many PRN medications. That's really important. So we should be reviewing as part of our daily assessment, and not just simply looking at the infusions, but looking at all their PRN usage and having a conversation between nursing, medicine, pharmacy to create a plan. These are some of our weaning guidelines, and I'll try to walk you through it. Our first point is that we look at how long have they been on it. And the key number of days is it more than 5 days? How do we know how long they've been on it for? Well, pharmacy will always put a note into the patient's chart as to the original start date that they've been exposed to that particular class. So it's not just simply the start date of that order, but the start date of when they were exposed to opioids or benzos or alpha-2s. Which drugs do we tend to wean first? It will be usually opioids. So when we realize that they don't need pain control anymore, then we try to take that off first until we can convert to enteral. Then we will put on the benzodiazepine wean and try to alternate the two. And the last class is the alpha-2 agonist, clonidine, because we can use the clonidine to help us wean off the opioids. So once the other two classes are weaned off, then clonidine is weaned lastly over 5 to 7 days. Second point, if they are on benzos, we will sometimes put them on a longer acting benzo to be able to wean off with less withdrawal. And so we convert, if they're on Midaz or lorazepam, to a longer acting benzo such as diazepam. The other reason why we chose diazepam too is that there is a enteral product for diazepam so that the patients can transition to the ward and continue their weaning. How do we convert the lorazepam to diazepam? It's a factor of 1 to 2. So when you calculate how many doses of Ativan they've used that day, and then you multiply it by 2, that gives you the conversion of how much diazepam that would be per day. And then you divide by the dosing interval to give you the dose. The third point I want to bring up is, what do we do with all the PRN orders? Now, typically post-operative, we see PRNs like every 2 hours. If we are now at the point where we're trying to take things off and ready to wean, they really shouldn't require every 1 to 2 hours of PRNs. So we try to convert or extend the intervals of PRN usage so to minimize the exposure. And if they needed it more frequently than that, then that warrants another conversation to see if we should slow down the weaning plan. And that is basically what I was talking about earlier too. The fourth point is how much do we wean the opioids off? Well, it depends on how long they've been on it. And if they are between 5 and 10 days, we will wean by 20%. If they've been on it more than 10 days, we will wean by 10%. And these are just rough guidelines. If we find it's not, we'll start off with that as a suggestion. And if it's not working, we slow it down. We either like wean it less, or we wean it less frequently. So the whole weaning process is very patient specific. The patient will let you know when they can be weaned or not, and it's great that nurses always do WOT1 scores to give us an idea of how the patient is tolerating it. And if the patient is able to take enteral meds or in tolerating feeds well, we can also switch over to enteral morphine and wean with that. Now, if there is a withdrawal, high withdrawal scores, then what are some of the options? Well, we can bolus that dose back in question, because obviously the patient is responding to us removing it. So we can give a little bolus back, or we can slow down the wean, either the interval or dose, or see if benzos might be necessary, but that would be really in the severe case of withdrawal. And other adjuncts only if opioids and benzos doses are already optimized. But generally, we find just slowing down the wean will help with the withdrawal symptoms. So how do we wean the dexmedetomidine? The patients that need a wean are those, I just want to say the information from how we decided who to wean the dexmedetomidine in our institution was based on a retrospective review done by one of our fellows, medical fellows, who looked at all the patients that were on dexmedetomidine infusions, and she looked at those patients that actually had withdrawal symptoms, and trying to find, is there any relationship between the dose and when a patient would go through withdrawal. And what she found was that patients that had over 107 mics per kilo of a cumulative dose, which is typically over 4 days, then or if they've been on long-term opioid use for more than 10 days, they would have to wean the dexmedetomidine. How quickly would we wean? We would wean by 0.2 mics per kilo per hour every 6, and no other wean of the drug is started at that time. If there are symptoms that happen, then we just simply slow it down or hold it until the patient is settled, and then we start at a slower wean. So this is, we tried to put this in a algorithmic form. And you will see that like dexmedetomidine infusions for patients more than 3 days on it, then we would consider weaning them. And I think that is it. If we want to transition them to clonidine to continue the wean, we can also do that. And we would start the clonidine. Here it says 4 to 5 mics every 4 hours. I'm not sure if we do it quite so high. It depends on their dose of dexmed at that time. And that is it. I said I was going to finish at 10 to 2.
Thank you, Karen. That was, again, a very comprehensive review of sedatives and the whole complexity of the weaning process. Thank you very much.
You're welcome.
Mm-hmm. So in the interest of time, if you do have questions, Karen is available by email. So you can email myself and I can just forward it on if you'd like. or you can do it directly at karen.wong@sickkids.ca.
That's right.
Yeah.
Thank you.
Bye, Karen. Well, you're welcome to stay on if you want.
Oh, okay. I might go outside. It's really nice outside.
Yeah. Okay.
Bye.
So are you still sharing your screen?
Oh, yes. I should stop that.
Gosh, I think you did.
Did I